So just a heads up that this meeting is being recorded and will be sent out to everyone that registered today. And if you don't consent to being recorded, you're kindly asked to drop off the meeting at this time or feel free to be off camera. So thank you everyone for your understanding and cooperation with that. Okay, Liv, go ahead and just admit everyone as you can, and Sarah should also be co-host, just a heads up. Okay, so I can welcome everyone now officially to our second part of our series with the Maternal Health Tribal Learning Community. It's hosted by us, the NIHB, the National Indian Health Board, in collaboration with CDC. And go ahead on the next slide, Liv. Oh, next one after that. And this is just a welcome from our lovely maternal health team, myself, working as a public health project coordinator. So welcome everyone. My name is Alicia Snetti. I'm an enrolled member of the Navajo Nation in New Mexico, but currently reside here in Baltimore, Maryland. And I'm here with our other team members, Liv and Sarah Price. And they'll be helping us support the webinar today and also moderating our breakout sessions later this in the presentation. So go ahead and next slide. And of course, I want to shout out our NIHB's mission statement, but with our own department, the Public Health Policy and Program Team, PHPP, our vision statement with working together to empower sovereign tribal nations to improve equity, policy, and public health systems that build thriving Native communities now for the next 7 generations. And go ahead, next slide, please. Okay. And so this maternal health tribal learning community, I welcome if this is your first time or if this is your second time coming to this series, welcome again. And we want to shout out that this partnership or this series is in partnership with our CDC partners who may be on the call as well. And just wanted to shed some light on our intentions of creating this space was really to create an environment where we can all connect and learn from one another and learn more about the work that we're doing or the work that we're doing in the maternal and child health field. So that takes up my part and I'll pass it on to Liv Hoynes.
Thanks, Alicia. So this is meant to be a community space where you can also meet one another. We wanted to provide some ground rules as towards the very end of the session, we will go into some short breakout rooms. We wanted to remind folks to remain curious and not make assumptions, to try and pause and listen first, that we expect effort, but never perfection, and that we are also here to build community and to connect with each other. We also wanted to remind people that you will have access to today's recording and to the presentation slides after the session. Materials will be sent out within a week post-event by email. The way that today will work is first we will have our presentation by Dr. Brian Thompson, who we're really happy to have joining us today, followed by a question and answer session. We will highlight some of the Hear Her resources for American Indian and Alaska Native communities, and then we will move into learning community breakout sessions and end our session and share an evaluation link with everyone.
Okay, perfect. All right, we can stop sharing, Liv, and then we'll have Dr. Brian Thompson upload his slides. And I did ask, and I would love for him to introduce himself. And just, I met Dr. Brian Thompson during one of my undergrad workshops with the AAIP organization. And just, he's a very respectful and honorable and knowledgeable leader in this field and an advocate for Native American healthcare. And I'm very excited that he's our speaker for this series, and he'll be touching on or speaking on cultural competency, but also touching on Native maternal mortality and morbidity. So I'll give it to you, Dr. Thompson. Thanks.
Awesome. Squilly Scano, can everybody hear me okay?
Yes.
Yes, okay. Because I can't see you, I can only see my slides, but Squilly Scano, Welcome and peace. My name is Brian Thompson. I'm a citizen of the United Nations here in New York. And I just happen to also be a OBGYN physician here at Upstate Medical University. Syracuse, New
Oh, Dr. Thompson, I think you muted.
Oh, can you hear me okay?
Yes, now you're back.
Okay, I don't know why that did that. But I'll go ahead and take myself back here. Everybody can hear me okay? Yes?
Yes. Yes.
Perfect. All righty. But my name is Brian Thompson. I'm talking to you from Syracuse, New York, upstate New York. It's about an hour and a half, a couple hours away from Canada, about 4 hours north of New York City, in the heart of the Haudenosaunee, the Haudenosaunee Confederacy. And I'll be touching on that a little bit. It's also known as the Iroquois. Iroquois is also 6 nations. We call it the Haudenosaunee. So I'm an OBGYN physician up here at Upstate Medical University with about 11,000, 10,000 employees. And I work in a regional high-risk OB unit. I'm actually working there today. So I see very sick referred OB patients and normal OB patients, as well as our native patients itself. So I'll go ahead and get started, and I hope you enjoy the talk. So what we're going to do today.
Real quick, Brian, can you go ahead and share your screen?
Yep.
Okay, perfect.
Let's see. Let me share screen.
Perfect. And then you'll just play from start. Yeah, you got it. Yay. Okay. Thank you.
And how's that?
Yes, perfect.
Awesome. Now I can see everybody. So that's great. So I'll go ahead and I'll get started then. So welcome again. So what we're going to do today is I want to talk a little bit. I'm a doctor. I'm a native doctor. I happen to be, I'm native first. I'm a physician second. But for today, I wanted to talk to you a little bit about a very difficult subject, is maternal deaths in our native community, as well as severe outcomes in terms of our native patients. I'm talking to you, and I give acknowledgement to the Onondaga people, the Onondaga Nation, on where I am right now, and but also to all the moms who have lost their lives, our people who have lost their lives during pregnancy and after pregnancy, and the children also. So it's a hard subject, but I wanted to talk a little bit about that today and the OB crisis that we're facing across the United States. Talk a little bit about some severe outcomes that occur within patients, some thoughts that I had, and some cultural thoughts, and then maybe just one solution. I'm not here to give really answers, but maybe to build some discussion and build some food for interest. So with that, we'll go ahead and get started. So, the United States has one of the highest rates of maternal morbidity and mortality in the world of any industrialized nation. As you can see on the slide here, the U.S. Has approximately, at least in this data here, about 25 maternal deaths per 100,000 deliveries. Incredibly high compared to other countries like France and Canada and the UK, as you can see here. And I think all have appreciated this over time. But what's alarming is why these numbers just keep increasing over time. I mean, back in the 80s, it was about 8 per 100,000 people died in the United States. Now it's way over what is shown on this slide of about 20 per 100,000. And when we start to look at really some of the most recent data that we have, and you'll get a copy of all these slides, and all this is public data. what we're looking at right now, and it isn't even in the midst of some of the deaths from COVID, but in 2021, we had over 30 deaths per 100,000 patients. These are native, non-native patients in the United States. When you really think about that number, 30 per 100,000 is like 3 in 10,000, or like 1 in over about 1 in every or 3,000 deliveries. So whenever you go in the hospital, about 1 in 3,000 patients may pass away during the course of pregnancy and thereafter. It's just incredibly alarming. And you look at the number of deaths that occur each year, and it just keeps skyrocketing up, as you can see. I don't know if you can see my pointer. Can you see my pointer at all on the slide?
Yes.
Perfect. All right, I'll be able to use that. As you can just see that the numbers just keep skyrocketing, and I'm sure they're much, much higher now. But you're talking about 1,200 maternal deaths per year, and just 2018, it was like about 700, and just incredible numbers. But how it really affects our native patients and our Black community itself. And a lot of times when we're looking at this data, it'll be introduced as and really highlighting and forgetting about the numbers in terms of our native community. The way that I look at it, and I look at maternal mortality, is really the Black and Native American community are essentially as one in terms of these incredible outlying numbers of dying during childbirth. But the numbers are very high for both, as you can see. And when we look at this data, and others have been very good at highlighting it much better than I'll ever be able to do, but it really gets difficult on how to tease out, the number of people that die during childbirth itself. And I'll show you one example of that. As we talked about before, is about 1 in 1,200 people that die. But really, when we look at some of this data, it's only during pregnancy, in the first 42 days after pregnancy itself. But when we look at some of our native data itself, it gets a little bit difficult to understand, and I'll show you why. So the Indian Health Services that we have, at least from the CDC, what they report is about 10 to 13 native deaths per year in the United States. When we look at other series of data from what we call maternal mortality review boards, it's about 17 deaths over 3 years. So again, about 5 to 6. But when you look at some data from Arizona shows that over 3 years we had 24 maternal deaths, or about 8 per year. So the numbers are completely different and much higher when we look at some of the data like from Arizona itself. And what happens is that this is some data that looks at what we call maternal mortality review committees from 36 states in the United States, and it looks at Native American, Alaska Native women. But almost about 30% of those deaths occur between 43 and up to 1 year after pregnancy itself. So we're missing a lot of numbers. And we don't really know what the true numbers are. And that's what makes it difficult. Like, for all of us to deal with statistics, we know that it's very difficult to really get at the true numbers itself. We're not really sure how many Native women are dying during that year after childbirth and during childbirth itself. We have some idea, but we don't really have very, very clear numbers. But what we do know is that when we look at our patients, our Native patients, our community, when we're looking at our patients, about a third of them are dying as a result of mental health conditions. About 20% due to bleeding, what we call hemorrhage, and about 10% for what's called amniotic fluid embolism, and about 10% from infection. But really, we start to highlight some of our mental health conditions itself. But why are these numbers just alarmingly increasing? It's really because our system, our medical system, is really breaking, and we can all feel it each day. Our patients are more complex that we're seeing. We have mental health crisis that's going on. We have less primary care providers. We have less OB providers. We have less maternity care centers, labor and delivery units, and birthing centers, and our funding is not where it should be. I wanted to show you this picture and just take a look at it of the United States itself. These areas that are in the darkest blue are areas where our mental health shortages are the most. But if you really look at the entire United States, there's really a mental health shortage of providers everywhere. But in some of these areas are our most vulnerable patients for our communities itself, as you can see. And when we look at primary care shortages, primary care doctors, another picture in the United States, the darkest green areas and the green areas are where the shortages are the most. I'm located right up in here, this little dot right up in here. But what you may not have thought about is what we call maternity care deserts, or areas that really are starting to lack care. When we look at the United States itself, this data from the March of Dimes is that this area in the middle, the darkest green, are counties that have no OB providers itself, no OB providers per 10,000 births. And when you look at hospitals, that counties that have no hospitals or no birthing centers, it's just incredible. We see these vast areas across the United States in our south, along the middle of the United States, in Alaska, out west. And what we call this, what March of Dimes calls this, is maternity care deserts. And what is a maternity care desert? So what a maternity care desert is, it's a county, an area that has no hospitals that provide OB coverage, no birthing centers that offer obstetrical care at all, that have no OB providers, whether it's midwives or OBs or family care docs, for 10,000 births. That's a decent amount of births. I mean, really a desert itself. And when we look at this across the United States, it's amazing if you've never seen this before. And like I said, this data is from March of Dimes that shows that there's these vast areas across the United States that have no OB care at all. And imagine what that does to our patients. Imagine what that does to our families. And you may not have realized that about 35% of all the counties in the United States are maternity care deserts, almost 1,100 counties in the United States. And another almost 350 have low access to maternity care. So like 50%, almost 45% of the United States has either a maternity care desert or low access to care. And you can start to appreciate why these numbers are so high in terms of why our patients are having severe outcomes and why they're dying. And just to show you that again, that incredibly vast area across the United States. So I wanted to talk a little bit, and I know this is a lot of information, but I wanted to just, like I said, I wanted to give you some food for thought, just a sampling of what the scope of this problem is and what the scope of this crisis is. And I wanted to look at some individual state data itself. Maybe you've seen this, maybe you haven't. But it was eye-opening, some of it to me. Arizona is deep to my heart. I'm a citizen of the United Nations. My wife is Danae. I worked at Phoenix Indian Medical Center, and so I lived in Arizona before I moved back to New York State, and Arizona is a second home to me. But about 50 to 70 women, native, non-native women, die every year in Arizona as a result of childbirth itself. And we want to, when we look at some of this native data, I want to show you some of this itself. I think I showed this to you before. Between 2016 and 2018, 24 native women died during childbirth itself, or the year after childbirth. But what's more incredible is that about 88% of those deaths on review were preventable in some way or another. And how did these patients, I say a very difficult subject, but how did some of these patients pass away? About 30% from accidents, motor vehicle accidents, another 30% from suicide or homicide, another quarter from natural deaths. And then of course we have all of our medical reasons why patients are passing away. And what we see again is that mental health, substance abuse also, but mental health is a big deal of contributing factors of why we're having some of this problem. And I think I showed you a little bit before that those rates of passing away during childbirth, we measure it per 100,000 births in the United States was about 30, give or take. In Arizona, it's about 25, depends on the year of data because it just keeps increasing. So it really depends on the year you're looking at. But when we look at our native patients in Arizona, it's about 70 per 100,000 patients. So much higher, just way beyond the measures of anyone else. But what I wanted to show you was, now it's difficult to kind of interpret this data and look at it, and it may not be a fair assessment, but it may be a fair assessment if you're from these communities. You know, where I grew up in New York, we have poor access to care, and we sometimes feel like we're in another world. But when you look at the numbers from Arizona, about 70 per 100,000, this is information from the World Health Organization. It looks at the maternal mortality rates for individual countries. Iraq, 79, Brazil is 60, Jordan, 46, Vietnam, 43. For the United States, it was 19, Mexico was 33. But really giving you an idea that where our native patients and these numbers are lying when you start to really compare them to other parts of the world. Like I said, it may not be a fair assessment, but it really depends on your point of view, because you may feel it's a fair assessment if you live in those communities. So let's take a look at another state, because you'll start to see a pattern here. Let's look at Minnesota itself. This is from 2017 to 2018. So for white patients, they're about 70% of the births in Minnesota, and they're about 60% of maternal deaths. But when you look at our native patients, they're only 2% of the births, but almost 10% of the maternal deaths. Just completely an outlier. The green areas for Black African American patients, just alarming. Both of those are just alarming. Let's look at Michigan, and we'll just kind of go around and look at some of these areas. Let's look at Michigan itself. When we look at Michigan, that rate is 91 per 100,000 for our native patients in Michigan who pass away. How about Washington State? Let's look at Washington State itself and start to appreciate some of those numbers. 290 per 100,000, just completely out of bounds with other races and ethnicities. New Mexico, for our native patients, 120 per 100,000. Let's look at Alaska. Alaska is measured theirs per 10,000 births. So you got to multiply this by 10. 190 per 100,000 births. I mean, just astronomical numbers. And what really is the heart of the matter and things to start thinking about is that when they reviewed native patients from 36 states in the United States and looked at native data, they found that 93% of native maternal deaths were preventable, essentially almost 100%. There was something that we could do to try to save their life. But it's not only that. Sometimes we don't talk about, and I don't hear about a lot in talks, is the silent crisis of maternal morbidity. And morbidity is an outcome, an event that occurs that may, what we're going to talk about is severe. And it's a continuum. So you come in and you have an uncomplicated delivery, but you may have a problem that occurs that is not severe, that occurs during the delivery itself. But we start moving up the scale. And what we're talking about are severe outcomes. The top, obviously, is a maternal death, but what we're really talking about is severe outcomes. And just like with maternal deaths, these numbers just keep skyrocketing up each year. And they're much higher now than they were just 3 years ago. And once again, the two outliers in this are our native population, Black population. When we look at severe events, and I'll show you what some of those severe events are. They're not mild things. So when you look at just this set of data itself, when we look at our native patients, it's about 100 of these severe events, and I'll show you what they are per 10,000 deliveries. You know, what does that really mean? It means about 1% of the patients who are native are undergoing a severe event, a severe complication during the course of childbirth. And what are some of these events that we're talking about? A heart attack, renal failure, respiratory distress syndrome, an amniotic fluid embolism to your lung, an aneurysm, cardiac arrest, a seizure, heart failure, sepsis, shock, a blood transfusion, a hysterectomy, being on a ventilator. I mean, these are severe outcomes. I see these from what I do on a daily basis in our high risk unit. So we're talking about severe things that occur. These aren't mild events. I'm going to go back to Arizona again. When we look at Arizona native, or excuse me, when we look at Arizona native patients itself, about 300 events occur per 10,000 deliveries. That's about 3% of every delivery. Now, it may not sound like a lot, but imagine that you deliver 100 native patients and 3% of them, 3 out of that 100, are going to have one of those events that I was showing you on that screen. That's just incredible when you start to think about it. If that was your wife, if that was your child. What about for native patients in Arizona that don't receive prenatal care and happen to live on one of our nations? That rate is 1,122 per 10,000 deliveries. That's like 10%. They have like a 10% chance of having some type of severe outcome, of living on our land, of being a part of where I would want to live. When we look at high blood pressure, and I'll show you why this one is important to me, it's about 700, or about 7% of the time you'll have a severe outcome if you have some type of high blood pressure during pregnancy and you're native. Just living on our land is a higher rate than not living on our land itself. I'm a doctor, I'm educated. My wife is an RN, is a registered nurse. Even for our native patients, if you happen to go to college, you have some college, or you graduate from college, your rate of having a severe outcome is higher than all of patients in Arizona, native, non-native, who don't even have a high school education itself. I mean, think about that a little bit. You may think that education is a protective factor. It's not. And these numbers are also the same for our Black brothers and sisters. And I wanted to show you Arizona again and just give you an idea of what some of these rates are. This is the Navajo Nation, where my wife is, grew up over here, Hopi. I mean, these numbers are just astronomically high when you compare them to the rest of the population in Arizona. And it's equivalent to other native areas in Arizona itself. But what we also don't think about sometimes is how it affects our children. Every time one of these severe events occurs, 26% of those babies are admitted to the NICU. The hospital that I work at, we have a neonatal ICU that's called the NICU. We usually have somewhere between 50, on a good day, 50 kids, but usually about 55, 60 babies that are in the neonatal ICU every single day. But a quarter, if you have one of these events, about 25% of the time, your baby's going to be admitted to the NICU itself. I mean, that's some high rates. And I wanted to talk a little bit and just give you some of my thoughts and talk a little bit about the area that I come from itself. And we always hear about this concept called 7 generations. You know, you gotta look ahead to 7 generations itself. You know, that phrase is from where I grew up, the Haudenosaunee. And what it really is talking about is, and I want you to think about this in the aspect of our native women and our native babies in terms of mortality and severe outcomes, and how we look at this problem, that we don't look at things for the moment. That's what it really means. Not really 7 generations itself, but we don't look at things for the moment itself, like our decisions that we do and our leaders that we have. We don't look at things for the moment, but we look to the faces that are yet to come. In my area, in where I grow up, the Haudenosaunee, you know, those faces are coming out of Mother Earth. Those are the faces that are yet to come. And that's who we're really thinking about here, right? We're thinking about our most precious resource, the next generation and the generation after that. So we're thinking always in the future, not just for the moment itself. And I want you to think about that a little bit as we start to try to maybe move on over the course of the next, hopefully, year or two, and we start to really come to some ideas of how we address this problem. This is, I don't agree with I may not agree with the amount of land that's here, but this is what we call the Haudenosaunee, and this is where I am right now, is this little area right here, the Onondaga. I'm Oneida. My dad is Mohawk. I grew up at Onondaga and Oneida and moved back to the city of Syracuse itself. But that concept of 7 generations came from the Haudenosaunee. And what is the Haudenosaunee itself? The Haudenosaunee are the people of the Longhouse. It's a confederation of now 6 nations, but 5 nations: the Mohawk, the Oneida, the Onondaga, the Seneca, and then added on Tuscarora. But before there was contact, and we always have been and always will be the people of the Longhouse. And we lived in these these areas where all of our clans, and Wolf Clan, where all of our clans live together as one, where we cared for each other, where we looked at each other, and we talked to each other. Families lived together. Family unit was so important itself. The things that occurred 1,000, 2,000 years ago, longer, still occur to this day. This happens to be a picture of the longhouse at Onondaga. Everything occurs in this in the longhouse itself. You get your name there, your native name. You're as a baby, you're introduced to the community there. You're married there. Your funeral may be there. But not only that, the governance of our people are decided here. The governance where chiefs and clan mothers, our title holders meet and discuss and where the future is for the generations, for the faces yet to come. So I wanted to go back to this a little bit. What sometimes people may not know what really the native population, the Haudenosaunee, are like. Onondaga itself is considered a sovereign nation. They don't accept direct funding from the U.S. government, from New York State. The Haudenosaunee issue their own passports. We have brothers and sisters that are on the other side of the river at Canada. Don't believe in a border. The air doesn't stop at the border. The animals don't stop at the border. And as Native people, we don't stop at the border. We're all one. So this idea of sovereignty, this idea of family, and it is so important to us. And the idea of the mom at the center, it's a matriarchal society itself, the Haudenosaunee. But I wanted to look at these key words that we always talk about of diversity and equity and inclusion and belonging. And I'll try to keep my words smooth and not sharp. But what diversity is, it's really differences, right? It's differences of race and ethnicity and gender, but really it's all that makes us who we are, however you define it. And equity is really talking about resources. All that makes us who we are require different resources and support. But when we look at inclusion, it's really value, that you have value. It's an external action. But what really we're all looking for is belonging, that you feel acceptance, and that's that internal feeling. So you may be included in something, but you're not belonging to it. That belonging is internal, that oneness itself. So let's look at equity a little bit. And this is kind of a very popular slide, and I'm sure you've seen this before. When we talk about equality, we may all receive some of the same resources, but it's not equal. We're not able to see what's out there. We're not able to appreciate everything to the fullest extent. But really, when we're talking about equity itself, what we're talking about is that some may need more resources than others so that we can all see what is out there, that we can all fully be valued and appreciated, and what we talk about in terms of belonging. So for our area, the Haudenosaunee, we like to use wampum in our wampum belts to teach a little bit. And one of the concepts, this is the one dish, one spoon belt. And it really is talking about equity. So what this is and what it means is this area in the middle is a dish, and food in the middle of it, beaver tail actually. And really what it is, it's a belt that talks about the resources in the Haudenosaunee in terms of hunting. That means that that you can go out and hunt in different areas. If you're Oneida, you can go to Onondaga. If you're Mohawk, you can go to Oneida. And we're sharing all of our resources itself. We're all eating out of one dish, and we use one spoon. And that spoon is a non-sharp utensil. And we try not to use sharp words itself. But what it really is talking about is that when we all sit around this dish, when we all sit around and we share that food, when we share those resources itself, we just don't take everything. We give it to the next person, allow them to take some of that so that they're fed, so that they have resources, so that everybody is full coming from that dish, that no one goes away hungry itself, and we're all sharing. But when we look at, and you may have seen this slide, when we look at the Indian Health Service in terms of funding itself, this is from National Indian Health Board in terms of their budget formulation information. When we look at Medicare spending, it's over $15,000 per patient. And we look at veterans, it's about $12,000, and Medicaid about $9,000. But when we look at Indian Health Service spending, it's about $4,140, $4,500 or $5,000. It doesn't really matter. It's just so off the chart. And is that really what we're talking about in terms of equity? When we're talking about our moms that are having some of these severe outcomes at these astronomical numbers or maternal deaths, is that really equity? Are those resources really appropriated adequately? What about our native youth that are going into medicine? I'm a physician itself. When we look at graduation numbers from medical schools across the United States, back in 2018-19, only 38 Native Americans, Alaskan Natives, graduated from medical school out of almost 20,000 students. Now, how do we build a healthcare system for our Native people with graduation numbers like that? How about, I'm a professor, I'm an assistant professor. But when we look at in our medical schools, how many instructors are there? How many professors, associate professors, assistant professors? When we look at 275, almost out of 200,000 instructors in our medical schools across the United States that are teaching Native and non-Native people. And what results? Invisibility of our people in terms of healthcare. Only 11%, this is from the Association of American Medical Colleges, about 11% of US medical graduating schools have information curricula that have Native content in it. 90% of our medical schools that are teaching doctors don't even talk about Natives itself and don't talk about these problems. So let's go on to inclusion. Value, you have value. So when we look at our Haudenosaunee people itself, Haudenosaunee governments, for us in our area, we talk about Mother Earth. Everything comes through the woman. My clan, I'm Wolf Clan. I'm Wolf Clan because my mother was Wolf Clan. My maternal grandmother was Wolf Clan. It's a matriarchal society itself. Everything revolves around the mom. And this is why it's so important for me itself. We have title holders. It's a traditional community itself. So we have clan mothers that are the heads of the clans themselves. And those clan mothers are picked by the community itself. So the clan mothers, over the course of time, will look at the community itself, and they may see young girls that are growing up, and they'll look at them and say, this one looks like a leader. and they'll watch them over time. The clan mothers give names. They give your name out. They kind of reach into what we call a basket, but they really have a names that they can provide. And each one of us only have one name. Like my name is Brian, but there's my name is Dehunja Esta, but there's only one of those in the entire world. So that when we speak to Creator, they know who we're talking about. There's only one. There would be only like one Brian. They're the decision makers. They're the ones that lift up and elevate the chiefs of our community itself. They determine the leadership. The clan mothers do. And the clan mothers are the only ones that can take out the leadership itself. They're the ones that can remove the chiefs. Our clan mothers ran everything and had the last word. And I think that's the answer. Just a different way of thinking. And I wanted to talk a little bit, and you may have seen this before, you may not have. This is the Hiawatha belt. This belt is at Onondaga. It's really talks about how the formation of the Haudenosaunee occurred. And I want to explain it to you a little bit, if we can, if I can, and look at this in relation to this idea of maternal mortality and morbidity, the problem itself that we're trying to resolve. So these are individual nations at this time when this belt was made. There were 5. Tuscarora came in later, but the Mohawk, the Oneida, the Onondaga, the Cayuga, and the Seneca. I'm Oneida itself. Right now I'm at the land of the Onondaga. The Onondaga is the capital of this confederation of individual nations itself. And they're connected by these lines. So what occurs to the Oneida may have effects on the Onondaga, Mohawk, or Seneca or Cayuga. But what it also means is that if something occurs that affects our individual nation itself, that it may affect the other nations, then it becomes a problem of all of us itself, where we all work together. And these lines on the end are so important. That means that anyone who wants to come under what we call the tree of peace are there. These roots reach out in all directions. So the Haudenosaunee were much larger. There were a number of nations that were a part of us in the past. But it means anyone is willing to join this confederation and be a part. And what we're really talking about is that when we're talking about our native morbidity, our native mortality, it's not just an issue for Oneida. It's just not an issue for the Haudenosaunee. It's an issue for all of us together, that we all need to talk as. This tree of peace that I'm talking about was planted next to Onondaga Lake. This is in Syracuse itself. For us, this is all real. It's not just imagery. And belonging, that idea of oneness, that you feel acceptance. And we have these ideas that we talk about, the good mind, Ganigoleo, and peace, Skana, and power and strength. And what we're really talking about is that when we're looking at things, that we try to use a good mind. We use a good mind not only within ourselves, but how we work with others. And when we do that, we start to have peace in ourselves and peace with others. But when we're all working together like this, we develop a power, we develop a strength, and we develop a power and a strength as a Native people to tackle some of these issues that we're talking about itself. And you may see these, you may not even realize it, but you see these concepts on a daily basis if you happen to have a $1 bill. The eagle, the United States uses as their national bird, was supposed to be a turkey, but for the Haudenosaunee, we all have leaders. So the leader of the birds is the eagle. and the United States moved over to the eagle. But in the claw of this eagle are these arrows, and there's a lesson within that from the Haudenosaunee. This was a Haudenosaunee concept, and what it means is that if each of our nations is a arrow, and when we put them all together and we wrap it with the sinew of the deer, who's the leader of the animals itself, we have a strength when we all work together as one. And it's unbreakable. We can't break those arrows. But each of us can unwrap that sinew, can take those arrows and bring them apart and break us down. And it's easy to break one of those arrows. Those are Haudenosaunee concepts. So we try to use that good mind, Ganigo Leo. And we look at diversity. There's no invite needed to try to help figure out this problem. Equity. When we look at our moms and our babies, that we don't need to ask for help within our communities, that we're all working together. Inclusion. Each of us are needed. And belonging. We all came together as one. And what can we do? And I just give this for some food for thought. And we're talking about these concepts of how to lessen some of the severe effects on our moms and our babies that occur during childbirth. One idea is a national or even a regional Native mortality and morbidity review committee. So let's think about this a little bit and try to look at it on a much larger scale. This is a study that's looking at what are some of the opportunities for care improvement for patients that had some of these severe outcomes like heart attack and stroke and blood transfusions and all the things we talked about on that slide a little while ago. And when they looked at those severe outcomes, severe maternal morbidity, they found that there were about 44% of patients where there was opportunity for improvement of their care. And the majority of that improvement had contributing provider factors. It means the providers could have done something maybe to improve that outcome. For an example, in terms of bleeding, hemorrhage, about 90% of those severe outcomes had provider opportunities for improvement. But let's look at this on Native patients on a much larger scale. Now, this is from the National Vital Statistics in 2021. There were about 26,000 Native births in the United States. If we look at it over the course from 2016 to 2021, there was almost over 170,000 Native births in the US, or about 29,000 per year. And I showed you a slide a little while back from Arizona that looked at the rate of severe maternal morbidity, these severe things that occur to our patients, about 3% of the time, 310,000 births. And what that really equates to is almost 900 severe events to our Native patients every year in the United States, 900. And if we were able to improve 44% of those, some data from California we were just talking about, that really equates to almost 400 improvement in cares a year in terms of our Native patients. And that doesn't really include our infant outcomes. By working together, we can improve the care of our Native patients. And part of that is through these review committees. They're not multidisciplinary committees for Native people. It may be our Native leaders. It may be our women, our communities itself. It may include like National Indian Health Board or tribal organizations, our health boards itself that occur within our regions. But really bringing everybody together, our midwives, our doctors, our community health aides, our traditional people, everyone coming to the table, coming together as one. And we look at some of these outcomes, and that really is what this committee does. I happen to be on New York State's Maternal Mortality Review Committee. And really what we're looking at is how to decrease and eliminate the preventable issues. Over 90% of Native patients can be prevented or have preventable events that can occur when as a result of review. And that's a lot. Just incredible numbers. And I'm just going to end here, and I hope that I kept on time for you all and I didn't bore you too much, but I wanted to show you a picture. This is my wife. Her name's Matilda. And I said she's Danae. I think we took this in Yellowstone, but this is Matilda, and Matilda said it was okay for me to talk about this a little bit, but when Matilda had her first baby, she's a registered nurse. She had one of those severe outcomes that occurred. She doesn't remember her birth itself. She was extremely sick. High blood pressure. She had something that was called HELP syndrome itself, and she delivered early. She delivered at 34 weeks, and my first son was in the intensive care unit, and that's him right there. This is the rest of my family. So I lived through this. My wife lived through this, and my family, and it means something to me in terms of reducing some of these things. So wanted to leave you with a couple words in our own language from this area, just to kind of end it a little bit. Agweku uskaji and dwawinuni guanigula. It means we all wrap our minds together as one. Gayantageha awadu ne kanjokwa, ne ganigolio galatskana, ne detonio duhak ne yungwanigu. So we want to wrap our minds together as one. And if it's possible, I'll try to help and be of assistance to help our people to use a good mind, to have peace. And that's the way that our minds will be. I hope you enjoyed the presentation today. I hope it kind of highlighted a little bit of the scope of the problem for our Native people, these incredibly high rates of maternal mortality, these incredibly high rates of maternal morbidity, that severe maternal morbidity that we don't always talk about, these severe events, how we can try to improve some of those, that they really do affect our families and our generations that are yet to come. And that if we can come together as a people, our Native communities, and work together as one using a good mind, that we will develop a strength together to try to resolve this problem. So that's it. And I hope I kept on time.
That was perfect, Dr. Thompson. Seriously, you always know how to create a space that welcomes everyone with such good energy. And I really do appreciate that about you the most. And would like to extend my heartfelt thanks. A lot of people are in the chat thanking you as well. And on behalf of NIHB, appreciate you taking the time to share your enlightening and impactful presentation on Native maternal health promotion, and just sharing a bit more about your background and values, and sharing invaluable practices that can be shared on how we can work together to improve the health and well-being of our mothers and families, just our Native communities overall. And like what you said, working together to come together as one. So that's something I reflected on and took away from. And I did put in the chat that we're welcome to everyone, for anyone, if they want to ask questions now, whether you want to unmute yourself, raise your hand, or drop it in the chat box. I'll give that space to our attendees.
Do you want me to stop sharing?
Oh, yes.
Let's see. Did I do that?
No. Oh, yeah. Go ahead, Matt.
Hi, Dr. Thompson. Can you hear me?
Yeah. I have no idea what my screen looks like for you guys, so but go ahead.
Yeah,
go
so I'm a junior at University of Wisconsin Superior,
Yeah,
and I'm pursuing a degree in education. And I'm just wondering if there's anything that educators can do to just create awareness with this issue, or just to really start a dialogue
yeah,
in maybe health classes, or something in that nature, I guess.
sure. No, absolutely. I think, one of the things is working with your Native communities, is reaching out to the leadership of your individual nation in that area, and speaking to them. I find that they want to, Native people want to be able to tell their story. They want to be able to share, but they want you to know them, not just visit and get a history in a 10-minute presentation, but they want to know that you know them, that you see them. But so I would say first and foremost is reaching out to your native nations in the area that you are, and try to have a dialogue. But also working through organizations like National Indian Health Board are so important. They're incredible, or National Urbans, or National Congress of American Indians, or Association of American Indian Physicians. What I can tell you in terms of education, at least for health, is that the Association of American Indian Physicians is working on developing a Native curriculum for healthcare, and it's hard. I mean, I purposely talked about my own area. I'm not in, I can't speak, to all the other nations in terms of we're all what we call Ongwe Hongwe. We're all Native, but we all have different beliefs. We have different ideas. We have different creation stories, but a lot of them are similar, but some of them are different. So all that needs to be appreciated. How Native people are what occurs in the area that I grew up in is completely different than what occurs somewhere else, is completely different than somewhere else. I think that idea of sometimes of developing just native principles, we're all so different, but yet we're the same. So, but I would say first and foremost is reaching out to your individual community itself and developing that relationship. You talk to them. What I've usually found is that they'll talk back. They want to be able to know that they are being seen and heard and appreciated.
Thank you so much.
Thank you. We'll take, if anyone has other questions, maybe one or two, or comments, we welcome those as well. And I see Felicia added in the chat, how much does the issue of racism and discrimination in healthcare affect these negative outcomes?
It's funny that you say that, because we were talking about this before we were on, and I developed so many slides just for this one talk that I had some slides in terms of discrimination and racism itself in terms of healthcare. So there was some data, and I reviewed so many different states' data that I'm going to end up getting the state wrong itself. But they believe it was New Mexico, and please forgive me if I'm wrong on that. But they asked everyone, what do they felt like they as a part of their race, ethnicity, if they were getting adequate health care, or they felt like they were being treated differently than other races. And they found that about 1 out of 5 or even higher were felt that they were having discrimination within their healthcare itself. When and next time I do another talk, I'll make sure that I put those slides in. But when in New York, when we look at maternal deaths, when we in our New York State Maternal Mortality Review Board, we look at ideas of discrimination and racism, and I think all state maternal mortality boards do. And what we find that a lot of times there's bias in our care, and that really gets back to some of the ideas of natives caring for natives, and we have such an inherent interest in our own people that we have that inner feeling, that fire that we want to do right by them. So is there racism and discrimination in healthcare? Absolutely. I think we can all appreciate that.
Thank you. I see two people raise their hands, so I have those questions. Cindy Gamble, I'll let you go ahead and ask your question.
Thank you, Alicia. Good to see you again. Wonderful presentation. Thank you so much. My question is about midwives and birth centers, and I'm wondering what you think about that. When we look at European statistics, we see that they have a different system where midwives see most of the first level of pregnant birthing people, and then if they need higher level of care, then they go on to the OB. And it seems like this is a system that would work really well for us, especially seeing the deserts that you just shared today, which were pretty darn astounding. And having birth centers. And I know our place in Washington here Cindy Gamble Clinkett. I work as a tribal community health consultant for the American Indian Health Commission in Washington State. And here in our area, we do hear that people do have high levels of concern over their experiences in hospital settings and hospital births. And so what do you think? And then how could we move towards that if you think that's a good idea? And Kunishtish for your presentation.
Awesome. Absolutely. Without a doubt, in terms of our midwives, our aunties, and our traditional practices. One of the proudest things when I was looking at this data, and this is another slide that I didn't include, I think I just ran out of some time, was that the highest rate of midwives that are care for any race or ethnicity is in natives, and by a large number. I'm so proud of that, that the university that I work at, that we have midwives that work within our office, that work within our high-risk center, that work within our high-risk labor and delivery unit, and that they provide honestly a better level of care than that I can ever provide. The tenderness that they're with their patients, the amount of time that they spend with their patients, that connection that they have, that they see them, they're not invisible. And I'm such an advocate for our traditional birthing centers. What is more, what is one of the most sovereign things that we can do as a people than to be born on our own land, to be born by our own ways. What is more healing? I think I just saw somebody, I saw generational trauma that came across my screen, or historical trauma. How do we increase those numbers of midwives within our community? And I think that it really is a big answer. It's proven. We have lower C-section rates in our midwife deliveries. C-sections are associated with some of the severe outcomes that we have. Whatever that we can do to try to increase our Native people to become midwives and work is so important. And really, I wanted to say, you said that you're from Washington State and the commission, when I looked at, and I think I put it on that one of those slides, is that that you were able to have a portion, an addendum, part of that report that went out, and that was so unique in terms of some of the states that I reviewed. The power that you have to try to impact, and the passion, the compassion that you have for your people is just incredible. And I see doulas on here too. We have a free doula service in New York as part of our area itself. So doulas and midwives are so vitally important.
Yes, thank you.
I don't know if I answered your question or not, Cindy. So
You did. That was a beautiful answer. Thank you so much. I just think that this is part of the solution for us, and maybe a lot of our intention and priority should be around this, because you brought up education too. That's another huge issue. So in Washington, in the Portland area, Washington, Oregon, Idaho, the Portland Area Indian Health Board is starting a CHAP program, a community health aid program. And so we are now working on dental health aid therapists, behavioral health aides, and now community health aides. And people are asking though, for what about maternal infant health? How are we going to do that? And so, yeah, I think we just got to put our heads together and start making it a priority. But thank you. There's a beautiful presentation. I learned so much.
can I ask you a question, Cindy?
Sure.
When I looked at your information from Washington State, I mean, it makes you cry. I mean, some of those statistics, it just, and I can see where the outpouring of support, the directed advocacy to say what is going on, what has happened. How is that accepted by state leadership, by the Health Commission and the people of the government of Washington State?
The American Indian Health Commission is a entity that was founded by tribal and urban Indian leaders like 26 years ago. And its primary mission is to work on improving the health for American Indian, Alaska Natives in Washington State. So there's over 20 years into this relationship development that you were talking about. And I think that, it takes, you always, with a new initiative, you always have to have staff there, right? You have to have, you talked about resources too. You have to have staff who can really pay attention and bring those issues forward. And so that's the purpose of the commission with our executive director and the consultants. We are there. And then we had a Secretary of State, Secretary Wiesman, a few years ago, who acknowledged that tribes in Washington State were part of the health infrastructure. So Department of Health, local health jurisdictions, the State Board of Health, and tribes. So he acknowledged us, and under his leadership, he really wanted to be sure that there was leadership, AIAN, leadership and representation on statewide initiatives, committees, programs, because in the past we'd really been left out. They never consulted with the tribes. They would just do things and tell them about it later. And so there's been effort on both sides to really have that relationship, which just 2-3 years ago resulted in the governor's native Health Policy Council.
Mhm.
So now the tribal leaders meet on a regular basis with the governor and his staff. But it's taken, decades to get to that point. But we appreciate that and a lot of advocacy on the tribal leaders, on community members. It's taken everybody to be talking the talk for a long time. But now we are at a point where things are going better in our state, and it's little steps, but we can feel. I appreciate you saying that, because sometimes it feels like we're not making much progress, right? It's such a big issue. Does that answer your question?
Yes, and I'm so proud of you, the work that you do. It's just amazing. If anyone, just Google Washington State Maternal Mortality Committee, you'll see that report on there. I saw that. It just, I couldn't put it down, and the thought that went into it, and I'm just so proud of the work that you're doing. It really is amazing. So yeah, I will go for all you do.
Thank you. I will share that with everyone. That means so much. Thank you very much.
Thank you so much, Cindy. And I'm so thankful I met Cindy last week in Atlanta, where we had a space to talk more about maternal health promotion in Indian country, and just so thankful to be in her space and sharing that great energy with her. I did see Leah had her hand raised, so go ahead, feel free to ask your question.
Oh, Paul, thank you. My name is Leah, and I'm the Traditional Birthing Program Coordinator for the Waking Women Healing Institute in Gresham, Wisconsin. And so what we do is we work with MMIWP families, SA women, and DV women. And in that, we wanted to create a space where we could stop the violence at birth. And so we're using some traditional Medewan ceremonial stuff that was allowed and passed on through my teacher's Doreen Day. I'm learning from her at the moment. So we are working on that. And in that, we were thinking about our relatives who are incarcerated. And these, their indigenous birthing rights that they may not have at all in these institutions. We're thinking about the women and the girls that are incarcerated. So the data that you were telling, the mortality rates, I guess my question is, do you have the data for Wisconsin, and is it separated to where these deaths occurred, or these big events that happen? Because I would like that data. I've been having struggle finding that data, and so I was going to sit down with one of the movements here called Free, who is presenting our legislation with the dignity bill to end shackling during pregnancy for women and girls, and to include an indigenous a doula Wisconsin program, which would include some of our indigenous doulas. So I guess my question is, do you have data on that? And if it is can we get it separated to where it occurred in prison or jail?
Sure, I appreciate your question, and I don't have the data for Wisconsin itself, but if I'll type my email in the chat, or if you want to give out my email, that's fine. But I'd like to connect with you, and let me try to see. Let me do a little bit of research and see if I can pull that data up for you. In New York, it's hard, and I'm part of our New York State Maternal Mortality Review Committee, and one of the biggest problems that I have, and I'm not sure if it's the same problem in Wisconsin, is that they don't separate out Native data. We're considered other. I'm not other. You're not other. We're Native people. So, we can't, I don't even have that data for New York State itself. So it pains me sometimes. so I can look at it and try to see if I can find some of that for Wisconsin itself. But you know, you know, I'd like to see it myself.
I appreciate it, Luann,
And I appreciate you. Can I ask you a question? You know, in terms of where you deliver, you know, to me there's nothing more healing than you know, of using our own medicine that we were given. You know, we of how you're how you're birthing. You know, how you know, how does it make you feel to be able to be a part of that, to give back to your community? How does, can I ask you, how does it make you feel?
I cried. I called my dad and I cried. And I told him how important things were for me. And I let him know what was going on. And he said, anything you're gonna do, daughter, you're gonna be good at. So it feels good because our relatives haven't had this choice for a long time. And we get to help in one of the first birthing lodges with the Potawatomi people here in Wisconsin, and bring that birth fire back after I don't know how many years it's been gone. So, are not gone, but you know, in that way. So it's really important work for me. Heart-centered work. I don't even want to say work. It's you know, I didn't have this choice due to boarding schools, due to colonization. I'm first generation out of that, and I just I'm being led. So I just keep showing up and being that hollow bone and doing the work, and I'm consulting with and learning from all of you. So, Luann, and thank you for asking.
You know, it reminded me of one thing that I was taught, you know, is, you know, you go to school to get an education, and education's a good thing, but you go to school to get an education, but learn your culture, your songs, your ceremonies, your language in order to survive. And that's what made us survive as people. Our cultures, our ceremonies, our language, our dances, everything that makes us who we are. So education is important. But just like I said earlier, you know, I'm a native physician. Native is first, physician is second. You know, you always have that idea in your head. So I thank you for all that you do.
Thank you so much, Brian. Brittany shared that you have such a peaceful voice and you create a safe space with it, and I definitely agree. And I see for Brisha, if you want to go ahead and ask your question. Looks like we got room for a couple more. So I really do appreciate everyone for just participating and being in this space with us.
Well, good afternoon. Thank you, Dr. Thompson. My name is Fabricia. I'm in the state of South Dakota, and I work for the state. I'm an epidemiologist, and I get to see those numbers, the deaths in our state, like other states where you have the most affected populations are Native American women. And I know that in our state, historically, we have been, our relationship between the tribes and us have been really strongly marked by mistrust, and by, like, sometimes we just don't listen. We haven't earned the Native American trust, honestly. That's one of the reasons why we don't really have as close a relationship as we could have. And I wanted to hear you, like, how can we, like, from the state, rebuild that relationship and, like, reestablish that trust so that Native American women are willing to, like, talk to us and tell us what they think is going on with their mothers and their babies? How can we, like, restart that, given that we are in a context of such historical, like, and they have good reason not to trust us? you know, I will be the first to acknowledge they have good reason to grieve the things that, you know, we have done in the past or not done, or like even sharing information, like, you know, how difficult it is for them to have access to their own information and stuff like that. So any wisdom that you can share on that matter, I would really appreciate.
You know, well, I would say, you know, for any people, you know, when I try to work with a patient, you know, I may see a number of people through the day, but when I'm with that one particular person, I try to talk to them and treat them like they're the only thing in the world at that moment in time. And you know, I can't speak, you know, for the you know, the leadership of South Dakota and the relationship between the government and the individual nations within South Dakota itself. But what I can say is that, you know, for the people in our area, the health concerns are valid. You know, they do have good reason to have to mistrust. I can only speak to my particular area itself, but you know, when you know, for the for the Haudenosaunee, you know, our resources have been taken away, our land has been taken away. The clinic that I was saying that I'm on Onondaga land, the clinic that we have is only funded with about $1.3 million for the entire community. New York State hasn't increased that funding in over a dozen years. You know, is, you know, would that cause you to have, you know, angst? You know, part of it is you know, it's funny. There was a wampum belt that I had a picture of that I was going to put in, and I pulled it out at the end, and it's called Gaswanta or Turon wampum belt, and it really talks about the relationship of when the Dutch came over to our land, and that relationship that they had with the people of the area here. And I wish I could pull that picture up right now. I pulled it off my slides, but essentially it's a wampum belt called Turo wampum, and it's white, purple, white, purple, white. And those two purple lines talk about relationship. It's really a belt of relationship itself, of how we treat each other. And what it says is that, you know, from the Haudenosaunee is that you Dutch, you came over here. As we travel down the river of life, you're in your boat with all of your ideas, your political views, your religion, your everything that makes you who you are. And we're in our canoe traveling down the river of life, side by side, with all of us that make us who we are as Ongwehongwe. And we're not going to pass anything on to you, laws that affect your people. And we ask that you don't pass anything on us, that we're sovereign, just like you're sovereign itself. And those white lines that are in between as you travel down the river of life, those white lines, those three white lines, is what I had mentioned before. A good mind, Ganigolio, peace, Skana, and power and strength. Those three lines as we travel down side by side. We still have that belt to this day, and we still live by that, of that relationship. You know, so we feel that on a daily basis. Our communities feel that on a daily basis. That breakdown relationship, we still hold by that, and we expect the same in return. When there's a doctor, you know, one of the biggest things is you know, what all patients want, what you want when you go see your doctor, what I want when I go see my doctor, is respect, to be visible, to know that you're being heard, and that you're a human being, that you're appreciated, and that you're going to be helped, that you care. So I think just some of those basic principles sometimes of people working with our Native communities can start to build trust, but that trust, is going to be built over time. And but I appreciate all that you do. It's a difficult situation.
Thank you, Dr. Thompson. Thank you. Obrigada.
Thank you, everyone. I think we are right out of time, but we're supposed to go in a breakout session, but just noticed the good space that we're in right now, and just hearing the different stories each of you had to share and questions. And I was learning myself just being in this space. So I really do appreciate Dr. Thompson for staying over time. And of course, everyone, our attendees and participants being here today and engaging with us in this space. So again, thank you very much, Dr. Thompson, for your tireless efforts, raising awareness and driving positive change in the field of maternal health and just Native empowerment. I've definitely always enjoy hearing your presentations. And I believe we'll send out your contact information, Dr. Thompson, as someone asked of how they can get in touch with you, if you're comfortable with us sharing out your.
Yeah, that's fine. Did you want to write that in, or do you want me to type it in?
Yeah, because usually after the webinar, we'll send out the recording to everyone, the modified slides, and of course his contact information, as well as our CDC maternal health resources related to the Hear Her campaign. So we'll all send that out to the post email, including the evaluation too. So thank you very much again, everyone. We'll connect you with those resources in the email. So that is all.
Well,
And
thank you, and IHB, and thank you for inviting and having this space today, and for having a good conversation. I hope you enjoyed the presentation, and I hope to see all of you and talk to you again soon, and learn from you. I'd like to hear what you're doing in your areas. I'd love to be able to know a little bit more.
Thank you. Liv, if you want to, I'll stop.